Okay, let's get started. Hello, everyone. It's noon on Friday, 30th October in Singapore. On behalf of the Sing Health Duke-NUS Global Health Institute, I'm delighted to welcome all of you to this webinar. Today's presentation is part of our Global Health Seminar Series, which we now present in this online format. These seminars had been going on for a while prior to our current situation and were scheduled for the last Friday of every month. They're usually held at 2 p.m. And so thank you all for accommodating the change in time today, but do look out for, these ongoing series. It's a real pleasure to have you all participate in this seminar series and become part of this growing global health community that we are encouraging in Singapore and in the region. We really want to have this opportunity to connect to everyone, again, in various parts of the world. So we feel that this current crisis has more than ever illustrated the need to come together, to study together, to understand and learn from each other. So that's a part of the effort behind this. And I really look forward to our discussions today and in our other seminars. So our speaker for today is Dr. Lee Jan Hao. Dr. Lee is a senior consultant at the Children's Intensive Care Unit at KK Women's and Children's Hospital in Singapore. He's also an assistant professor at Duke-NUS Medical School, and a faculty of the Sing Health Duke-NUS Global Health Institute. After completing his undergraduate and postgraduate training in Singapore, he completed his advanced fellowship in pediatric critical care at Duke's Children's Hospital in Durham, USA. He has been actively involved in the setting up of collaborations in Asia via the Pediatric Acute and Critical Acute Medicine Asia Network, PACCMAN as it's known for short. And in today's presentation, he will talk about establishing a research network under the auspices of PACCMAN to look at issues related to pediatric acute respiratory distress syndrome. So he's going to give you all the details. I'm not going to go into it more now. A few housekeeping notes before I hand over to him. Please keep yourself on mute during the presentation at all times. The webinar will be recorded, so you should be aware of that. You can post your questions via the chat box at any time during the presentation, and they will be addressed at the end. So let's keep a lively discussion, and I look forward to it. And Jan Hao, over to you.
Right. Thank you, Amina. Let me share my screen. Yeah, all right. Very good afternoon to everyone, and thank you for joining us. And thank you once again, Amina, for the invitation to talk to everyone today in this global health series. And so over the next 40 minutes or so, I'll be really discussing my team's effort over the past couple of years in trying to establish research collaboration within Asia. So for this presentation, I have no conflict of interest. However, some of the work that's being presented today, we did obtain some grant funding from Sing Health Foundation as well as the Cruz Foundation. And I'll highlight these along the way during my presentation. So really, over the next 40 minutes or so, and I do have a disclaimer here, I've not given a Zoom talk for 40 minutes, and so please bear with me. I even have my water ready in case I run out of breath. But over the next half an hour, 40 minutes, I really want to share with you some of our experience, and really to start off with establishing why we need a research network in Asia. And that's why the idea of a Pediatric Acute and Critical Care Medicine Asia Network, or PACCMAN for short, was established. I'll briefly go through the history of PACCMAN, and then I'll really dive into the main topic for today is really the Pediatric Acute Respiratory Distress Syndrome, or PARDS for short, and describe the epidemiology and the current management that we are currently doing in Asia. And we'll finally end off with some directions and conclusion. So our work really started really in KK Women's and Children's Hospital in Singapore, and this was close to 6 years ago now. And we wanted to look at what was our experience in PARDS in our center. And so the group of us in KK decided to look at our own data And so we extracted data over 4 years from 2009 to 2012, which is close to a decade ago. And at that time, we actually gathered data from 70 patients in total. And what was humbling and remarkable was, if you notice here, the non-survivors outnumbered the survivors. And when I, showed this to my boss at that time, my head of department at that time, he was quite surprised. And I said, data don't lie, and perhaps, it's time for us to look at our practice and our outcomes. So if you look at the table here, really close to 60% at that time did not survive PARDS, which is a severe form of lung injury for children as well as adults. And then we look at some of the clinical characteristics of who are these patients who are not surviving. And we found that those with multi-organ dysfunction or failure during the ICU stay, as well as those with comorbidities, didn't do so well when they get ARDS. So what did we learn from this single center experience? So I think the team and I, really found out that we are dealing with a fairly small number of patients, and over the 5-year period, we only had 70 patients, and that's really quite small. And as I mentioned earlier, our outcomes were not that great. Looking at our data, only 60% of patients survive, and so obviously we asked, can we improve our outcomes? And we were at that time also thinking, is it just us, or is it fairly similar across other countries in Asia? And so, how can we then start looking at our experience and comparing them with other countries? So to look at the epidemiology around the region as well as worldwide, then my team and I started looking at the medical literature. And so what we did was really a systematic review and meta-analysis of ARDS in children at that time. And while we were doing that, we were somewhat quite surprised that another group was also looking at a similar question. And this group from Netherlands, led by Laura and her group, published their result in critical care medicine. And we, our team here in Singapore, published our result in the Journal of Intensive Care Medicine close to 3 to 4 years ago. So I just want to just spend a bit of time describing the results of these two systematic reviews, really to understand the global epidemiology of ARDS in children at that time, and how that sort of started the process of us trying to gather more data from Asia. So the systematic review performed by the group in Netherlands, they started out with an aim to estimate the population incidence. And of course, they wanted to estimate the mortality of children with ARDS. They used the common medical databases, and they restricted their search to 20 years, mainly from 1994 to 2014. They included both retrospective and prospective studies, but they didn't want studies that were fairly small. In contrast, our systematic review, our main aim was to describe the mortality over time. We wanted to find out whether are we, as a pediatric ICU community, were we improving in our care of these children? And similarly, we used 3 large databases. In comparison to the other systematic review, our search was much longer because our main aim was to describe the mortality over time. We only included prospective studies, and we also didn't include studies that were too small. So, after conducting the search, actually, you realize that actually these two systematic reviews sort of ended up with fairly similar number of studies, albeit they are quite different. But the group in Netherlands, had about 30 studies, depending on the outcomes they were looking at. And for us, we also had close to 30 studies. So this was what the group in Netherlands found, right? And not surprisingly, and this was also reflected in our single center experience, the population and the PQ incidence of ARDS is indeed not large. It's only about 3.5 per 100,000 person years. And the ICU, it only contributes close to 2.5% of the ICU admissions. And in their systematic review, they found that the overall mortality is about 34%, which is somewhat much lower than what we had in our first study, that was 60%. So this group went on to compare the results of the mortality of PIDS ARDS, across regions. And in Western countries, the overall mortality was 27%. And in contrast, in Asian countries, the mortality was 50%. And this was quite close to what our estimate was in Singapore, where it was 60%. And so the results of this systematic review really highlights that there is a disparity in mortality outcomes between Asia and the rest of the world, or at least with the Western countries. And the authors also went on to say that, based on their results, the Asian cohorts have higher mortality. And also they did some short-term mortality trend, and they say there was no change in mortality over Asia. They did a bit on study designs, whether that influenced mortality, and both retrospective and prospective study did not influence mortality rate. So what did we find in our systematic review? So this world map generally shows the studies that were included. And what is obvious really is, even though Asia is the largest continent in the world, we really have a very small number of studies, both observational and randomized trials, that was conducted in ARDS in Asia. And you can see that a huge majority of studies were conducted in North America. And we found that the overall mortality was 24%, fairly similar to what the Netherlands group had found in terms of the overall mortality. And bearing in mind that our main aim was to describe the mortality change over time, you can see that this forest plot shows nicely that over time, the mortality was getting better. And so we found that a later year of a study was associated with better survival. And of course, we also went on to describe whether there's any differences in mortality based on whether a randomized trial was conducted versus an observational studies. And we did not find any mortality difference. So what did we learn from conducting these systematic reviews and from gathering some information from efforts from other study groups? So what we realized is, in Asia, majority of studies were conducted within a single center setting. And even though there are multi-center studies in Asia, but multi-center studies are mainly limited to a single country. For example, there are studies involving multiple sites in Japan, but they rarely do they extend out within the country. And so what really spurred us and made us realize is there is indeed a lack of pediatric critical care collaboration within the region. And based on the mortality number, the difference based on the systematic review from Netherlands, perhaps the epidemiology may indeed be different in Asia. And so building on our experience in the single center study, as well as the results of our systematic reviews, we as a group came and really sat down and said that we think that we need a research network within Asia to try to increase the collaboration between sites in Asia. And that's how the idea for PACCMAN, or Pediatric Acute and Critical Care Medicine Asian Network, came about close to 6 years ago. So over the next couple of slides, I really would like to walk you through the history of formation of PACCMAN and how, through persistence and through some networking, this network has grown over time. And so, as I mentioned, this effort actually started close to 6 years ago. And it was in May 2014 in the World Congress of Pediatric Critical Care in Turkey, where we met, some of the delegates from Asia, and that is where we met our first two collaborators. And they were presenting their data on ARDS, and one was from Vietnam and the other one from Thailand. And what struck us at the time was their epidemiology was fairly similar, with them reporting fairly high mortality rates in children with ARDS. So after that meeting, we sort of kept in touch. We went on to publish our single center study that I highlighted earlier on. And we started some preliminary discussion, about the possibility of doing a multi-center PARDS study. And so we, kept communication with the first two collaborators that we met in Turkey. And based on their feedback, we went ahead and, decided that we need to have an online database where sites can start entering data. And of course, we need the necessary ethical approval to conduct such a study. Because we need an online database that can reach out to many countries around the region, we contacted the Singapore Clinical Research Institute, SCRI, on the possibility of working with them in making this database. And so, they were quite, interested in the work that we're doing, and they have, at that time agreed to say, okay, let's do this together. And over that year, we went on to recruit more sites, and another site from Singapore, NUH, joined us, and we also included some hospitals from China and Malaysia. And so, because this work, even though is small, we needed some small funding. And so Judith, who is one of my colleagues in the ICU at that time, also went ahead and applied for the Cool Pilot Award, which actually gave us a small sum of money to do this first study in PACCMAN. And so really the formal idea of PACCMAN was really established in the next World Congress held in Toronto in Canada, and that was in June 2016. And so at that time, before the World Congress and during the World Congress, we were quite active in gathering interest within Asia to see whether anyone else would like to join PACCMAN. And over at that period of time, close to 6 sites were joining us. So then, based on the interest of the 10 initial sites across Asia, we went ahead and collected data retrospectively on children with ARDS, and then we put them into this online database that was set up by SCRI. And really, the fruits of our labor were finally, realized in January 2017, where PACCMAN presented first results of this study in the Critical Care Congress in the US. And for those who are not familiar with Critical Care Congress or Adult ICU, the Critical Care Congress in the US is one of the premier conference for critical care. And what is more amazing was our work was recognized as worthy of scientific investigation. And actually 2 of our investigators at the time, Ligia from NUH and Judith from KK, based on the data that we have, they were awarded research awards. So building on the momentum, we held our first PACCMAN meeting in April 2017, and you can see that these are the really so-called the pioneer members of PACCMAN. And we held our meeting in KK Women's and Children's Hospital in Singapore, and really it was indeed a landmark day in April that we had our first meeting. So moving on, we utilized the data that we collected on the ARDS patient. We went on to present dig deeper into the epidemiology of ARDS in children. Our first PACCMAN contribution to the scientific data was really in November 2017, when our paper was published in Critical Care Medicine. And at that time, PACCMAN as a research network wanted to look at other important areas in pediatric critical care. And so, together with, Dr. Chong or Shuling from, Children's Emergency, we went on to secure a SingHealth Foundation grant to study pediatric traumatic brain injury, which is an important public health issue within Asia. And so, to keep members, engaged, we held our second PACCMAN meeting in Singapore in conjunction with the World Congress then. And you can see that the number of members or interested party has indeed grown over the past year. And so, as our numbers in sites growth, we continued the work that we were doing in ARDS. We held our third PACCMAN meeting in March last year in Indonesia. And throughout this discussion with our members, we realized that respiratory illness is indeed an important topic here. And so we went ahead and secured a grant from the Academic Medicine Sing Health grant to study severe pneumonia in the region. And because infection is important, we also collected some data in severe sepsis. So fast forward to what happened last year, we continued to contribute to the scientific literature. And actually in March 2020 was supposed to be our 4th PACCMAN meeting in Shanghai. But I think many of you would know that that was not meant to be because of COVID-19. And instead, what we went on to plan or to have is our first virtual meeting, which we had in April. And we went on to publish our results on traumatic brain injury based on the grant that we obtained a year and a half ago. Because of COVID, our sites went on to discuss on how we can collaborate in terms of pediatric patients that were admitted to the ICU. And actually later part today, we are having our 2nd virtual meeting, and that's why we have to push forward this global health session to 12 noon instead of 2 p.m. So I just really wanted to, just summarize that over the past 6 years, really PACCMAN has grown in strength and in, number of diseases that we are studying. But what we really want to just highlight the experience that we had conducting our first study, and that is on pediatric acute respiratory distress syndrome. So the rest of my presentation really will focus on PEDS ARDS and how, through a network, we managed to highlight and to find pertinent things that's happening in Asia. So just to dive into PARDS, unlike the adults with ARDS, where the definition has been quite established for a couple of years now, with the most recent Berlin definition, in children, the definition of PEDS ARDS unfortunately was only about only 5 years ago, where a group of experts came together to meet and to define PEDS ARDS. And so this consensus conference on acute lung injury came to define PARDS. They recommended certain things for management, and they highlighted some research priorities. So how do we define pediatric acute respiratory distress syndrome? So really, because we're dealing with children, and neonates are part of our patients that we see, but we want to make sure that we did not mix these diseases together with perinatal lung disease. So the definition excludes patients with perinatal lung disease. It must be acute in nature, so we're not dealing with anything that's chronic or long-term, because one of the features of ARDS is pulmonary edema. We want to make sure that that's not contributed by cardiac failure or fluid overload. We need some sort of imaging. And really, the hallmark of ARDS is really hypoxemia. And so this definition includes, different degree of hypoxemia based on the oxygenation index. And then we categorize them into mild, moderate, or severe. So this is what PALICC, or the consensus group, has defined ARDS in children. And they also highlighted that because, as pediatricians, we manage certain special population, unlike in adults. We deal with children with cyanotic heart disease, where they at baseline has already hypoxemia. So how do we define children with acute lung injury or ARDS in children who are already hypoxemic at baseline? So they put some criteria there. We deal with children with chronic lung disease. Our neonatal colleagues are doing a much better work now. Many of their ex-premature infants have chronic lung disease requiring oxygen. So how do we define ARDS in this group of patients? And as mentioned, we really want to exclude those with left ventricular dysfunction or cardiac failure in our definition. So when PALICC defined this definition back in 2015, there was no validation of this definition. And so, as a group, PACCMAN decided that one of an important contribution that we can make really is to use the data that we have to validate this new definition. So what we did was a multicenter retrospective cohort study, and we then collected data from children with ARDS that was admitted to our ICU over a period of time from 2009 to 2015. And so this first study, involved 10 sites across 5 countries in Asia, and we, follow up these patients up to 100 days. And for this initial study, we only included patients on invasive mechanical ventilation. So this retrospective, multi-center study, we managed to recruit close to 375 children. And you can see that, slightly close to 2/3 of patients had moderate or severe PACCMAN ARDS, right? And this graph just shows that, just want to highlight here that the oxygenation index or the degree of hypoxemia is worse in those with moderate and severe ARDS compared to the mild group. And so what did we find in this retrospective study? We found that the PICU mortality is 30%. And if you remember the number that was quoted in the meta-analysis earlier on, it was fairly close to the number or the overall mortality of 25 to 29%. And if you follow up these patients longer, up to 3 months, their mortality is somewhat a bit higher, close to 40%. So if you look at this survival curve, and the dark blue line shows mild ARDS, the dotted red shows moderate, and the green dotted line shows severe ARDS. You can see that based on the classification of the PALICC definition, there is good separation between the 3 groups, meaning those that with severe PARDS did not do so well, or they are more likely to die. And so we went on to calculate the hazard ratio, and you can see that with reference to the mild group, those with moderate ARDS in children had close to 2.5 times more likely to die, and those with severe PARDS had close to 4 times more likely to die. So this sort of, is one of the first few data across the multi-center settings that show that the new definition by PALICC is quite robust because it predicts quite well the mortality separation between the 3 groups of ARDS. We went on to look at some secondary outcomes. We look at ventilation-free days, duration of mechanical ventilation, PICU-free days, as well as duration of PICU stay. And really, if you compare among the 3 groups, there was separation between the 3 groups again between these secondary clinical outcomes. So since our publication of this multi-center PARDS in Asia, there was a larger study that came out, and this was published in the Lancet Respiratory Medicine in 2019. And PARDS really is the international observational study of PACCMAN ARDS that was led by Robbie Kimani at UCSF. And what they did was they took a snapshot of children with ARDS over a period of 10 days, over a period of 1 year. And what they found really was they have close to 700 patients, so a much larger study than what we conducted. But I just want to highlight that looking at the region, and if you look at the Middle East, Asia, Australia, and New Zealand region, they only had a total of 40 patients, meaning that even though this was an international study, the data coming out from Asia was still quite limited compared to what we did in our prior study, right? And so even though this is an international study, majority of the patients described comes from or came from North America and Europe. So since we were collecting some data on ARDS patients, and for many of us in the ICU, both in adult and in pediatric ICU, mechanical ventilation is the cornerstone of management of these children with severe lung injury or severe hypoxemia. So we wanted to collect data on how we are managing these patients that were being admitted to us. And so together with the epidemiology data that we had, we collected mechanical ventilation settings and wanted to see and study how we were treating these patients or managing these patients. And so using the same cohort of close to 375 patients, we looked at how we were ventilating them across the different severity groups. And so, what I want to highlight from this table is, in severe PARDS, there was an over high percentage of patients that were, ventilated with high frequency oscillation. And I'll touch a bit on this in my later slides. You can also look at those that are with most severe lung disease. We were using fairly high ventilator settings, and for those who are not so familiar with mechanical ventilation settings, the peak institute pressure here, generally we do not want to go above 30. And you realize that, really we were using quite high settings, in children with, severe ARDS. And finally, we look at tidal volumes, which is how much air we were giving to the patient in the ICU. And, this was somewhat surprising because if you look at, the numbers here, it ranges from 8 mils per kilo to 10 mils per kilo. And why this is surprising is because one of the dogmas that we follow in ICU care is for patients with ARDS, we try not to exceed 6 mils per kilo. So obviously, while we know what is the ideal target, on the ground, we were really not following some of these guidelines that were provided to us. So this was indeed fairly surprising. So we also examined what were our goals of gaseous exchange, meaning the values of the arterial blood gas that we were doing for these patients. And really the general consensus of the guidelines was we try to accept some permissive hypoxia and permissive hypercarbia if possible, because we do not want to injure the lungs of these patients. And so we look at the graph that were of these EBG values. And I just want to highlight some of these and walk you through these 4 graphs. So this is the partial pressure of oxygen. And realize that this curve shows the distribution of PaO2 for the 375 patients. And you realize that the mean is close to 75. And there were patients that were achieving very high PaO2s, which was not what is being recommended, at least by the current guidelines. And if you look at the saturation, an overwhelming majority were hitting 96%. Right? And we really wanted, or at least the guidelines say that it's okay to not score full marks at 100%. It's okay to be in the high 80s or low 90s, but overwhelming majority of patients were achieving 96%. How about PaCO2 or the partial pressure of carbon dioxide? Again, although the guidelines advocate for permissive hypercarbia, we were just achieving the limit of upper limit of normal carbia. Right? Again, we were not very comfortable allowing our patients to have a higher range of CO2s. And finally, because if you allow CO2 to be higher, our pH should be lower. But again, our most common pH value or the mean pH value was 7.4, which is not permissive hypercarbia. Right? So again, consistent with what we found in our mechanical ventilation settings, our targets or what we achieve in gaseous exchange were also not fairly consistent with the current guidelines. So that brought our group to think about, can we change our practice? And so within, with the help of some of our nursing and respiratory therapists in our ICU, we wanted to see whether we can introduce the PALICC recommendation within our ICU. And we wanted to introduce a ventilation bundle, which the PALICC group actually sort of provided some best practice recommendation. And it included peak pressure limit, some tidal volume targets, some oxygen concentration PEEP titration table. They put some targets for permissive hypercapnia and permissive hypoxia. And so we conducted a pre-post study in our own ICU in KK. And really, these are some of the protocol elements that we were trying to target. And just want to highlight, briefly talk about permissive hypercapnia. We wanted a pH of 7.2 to 7.3, right? And, in permissive hypoxia, in those with severe ARDS, we wanted, a target of, high 80s to low 90s. So what did we find in our pre-post study within our single center? So, we have roughly similar numbers across the 2 periods. And really, I just want to show this table to show that in the 2 study periods, there were no difference in clinical characteristics between the 2 study periods, right? And so we want to examine before the protocol was established versus when we introduced the protocol after a wash-in period. So we looked at, conventional mechanical ventilation days and wanted to look at, did we make a change in tidal volume prescription as well as other ventilator parameters? So although the p-value is significantly different between the 2 groups, non-protocol and protocol, you realize that the degree of change is not that much, right? It's 6 mils per kilo versus 6.4, right? And if you look at, the use of positive end exudative pressure or PEEP, even though this is significant, really there was not, in pure numbers, it was only, it's actually 8 compared to 8. So although there's some difference in statistics, but one may question whether did we really make a change with the introduction of the protocol. So nevertheless, we went ahead and did an adjusted survival analysis, controlling for certain important covariates such as how sick the child is, how sick the lung was, and and study whether the introduction of the whole bundle, meaning the 5 bundle parameters, whether did they make a difference? And indeed, you can see that a lung protective strategy or protocol resulted in a much lower hazard ratio, right? And so this Kaplan-Meier survival curve and the protocol period is highlighted in yellow. It shows that they have a better survival, at least in our small study period, our small study sample. However, because it's a bundle, we can't really tease out which component of the bundle really made the difference in improving the survival. So what lessons did we learn from conducting this study within our ICU? So we realized that human behavior is hard to change. Even after introducing that protocol in our ICU, some of the ventilation parameters that I've highlighted, there was really quite minimal clinical change, right? However, is the dogma true? Because the ventilation bundle that was being proposed by PALICC was not backed by strong evidence. It is, based on retrospective studies, observation studies, but there is to date no randomized trial to test on, the effectiveness of such an approach. So what our team has done is really we are now back into our drawing board to discuss the best way to test this in a pragmatic manner within PACCMAN. And there is currently an ongoing study looking at this. So I just want to end off, in the last 10 minutes or so, describing the rest of the epidemiology of ARDS in Asia, and really want to focus on the outcomes of children with extrapulmonary ARDS, as well as the use of high-frequency ventilation in ARDS. So for those of us who are in the ICU, we know that PARDS or ARDS is the final lung injury when a patient is very sick, and the inciting agent or the inciting event can come from the lung itself, meaning a pulmonary cause of the ARDS, or it can come outside of the lung, meaning the extrapulmonary ARDS. So examples of this includes, severe sepsis, severe trauma, severe pancreatitis, for example. So using the data that we have collected, we wanted to look at whether there was any difference in children that had a pulmonary cause of ARDS versus those with extrapulmonary cause. And so, as we work through this flow diagram, we wanted, to look at patients with a single risk factor. And so, we have an overwhelming majority of patients with pulmonary cause of ARDS, but we do have about a quarter that was, due to extrapulmonary reasons. So this table shows the distribution between the two groups. And what I wanted to highlight here really is those with extrapulmonary ARDS, they have more bacteremia, they were generally sicker or more ill when they were admitted to ICU. And more importantly, this group that had extrapulmonary ARDS had more multi-organ dysfunction, meaning in addition to the lungs, the other organs are more often involved. So how about the clinical outcomes of these two groups? What you can see from this table here is, children with extrapulmonary ARDS, they had close to 2-fold increase in mortality, 46% versus 24.3%. And really, if you look at this survival curve again, the blue line, which denotes extrapulmonary patients, they were really not doing very well, compared to those with pulmonary ARDS. So we went on to also look at, duration of mechanical ventilation. And again, although it didn't reach significant, they were somewhat, require a bit of longer ventilation duration, but they have also less ventilation-free days. So we went on to, adjust for other important covariates in our model to determine whether extrapulmonary ARDS indeed is a factor that is important in our patients, And so what we found really was, after adjusting for some of the important covariates, the fact of them having an extrapulmonary cause does not make them do worse. But what is really driving their worst outcome is really the presence of multi-organ dysfunction, whether they have comorbidities, how sick they were initially. So, what we found, at least with our data set, is, extrapulmonary ARDS is a small subset of our patients. They generally do worse mainly because of the other organ involvement and not just because of the lung. So, I just want to end off this section on the use of high frequency ventilation. For those of us in the ICU community, we do know that high frequency ventilation has been, have gotten quite a bad press in the adult literature following the Oscillate and the Oscar trial. And these are two large studies published in the New England Journal 7 years ago, where they show that high frequency was bad in ARDS in adults. But there are some limitations to this study, but I won't have time to go through them. But in contrast, in pediatrics, even the expert consensus statement did provide that there is an indication to use high frequency ventilation. And when your conventional ventilation exceeds, a PIP of 28, perhaps you should consider using high frequency. So in contrast to adults, the current pediatric recommendation was still fairly for using high frequency. So we did a quick review on high frequency versus conventional ventilation in ARDS, and 4 years ago, there was really no big randomized trial, right? It was only very small single center or small multi-center studies, and the largest really was only RCT of close to 60 patients. And really this large study was really a database study. So because the use of high frequency is still fairly controversial, as a team, in PACCMAN, we decided that let's use our data to try to study, the use of high frequency in our patients. So, we did this work together with, statistician from the School of Public Health in NUS. And really what we did was we used fairly advanced statistical methods to conduct a match study based on observational data. So I just want to draw your attention to this original cohort, right, that have nice, mechanical ventilation data. So we used data from about 300 patients, and we divided them into two groups: those with high frequency was used versus those without. And basically, what I want to highlight here is there are differences between the two groups, meaning the clinicians or the patients that we use high frequency on are indeed different. So just for example, those with high frequency ventilation, they were much sicker and they have a much more severe hypoxemia. So basically what we did was we used a statistical method, and this genetic matching has nothing to do with genetics, but it's basically just a matching method that uses propensity score as well as individual covariates. So what we did was we tried to match the patients and try to make them a bit more comparable. And so after matching, we realized that we were fairly balanced in terms of comorbidities as well as the degree of hypoxemia. Meaning after this matching that has been done, we can then compare fairly robustly the use of high frequency versus conventional ventilation. So what was the clinical outcomes that we found? So after matching, we found that the 28-day mortality was indeed higher in those that were supported with high frequency ventilation, with an odds ratio of close to 2. And so we did a number of sensitivity analysis, and all showed similar direction. And needless to say, when this paper was published, we received quite a swift response from the investigator of PROSPECT, which is the Prone and Oscillate Pediatric Clinical Trial. So this is a large clinical trial that is being currently conducted by Martha Curley, Martin Neiber, and Ira Scheifertz in the US. And so while they were recruiting for this trial, we decided to do something that didn't require that much time and much less money. And so when our results were published, of course, they responded fairly quickly. And to be fair, I think, the take-home message from our study really is not to abandon high frequency, but really to wait for, the conduct of this trial to make further recommendations. So, based on our experience that have been, in PACCMAN as well as in our own studies, what we have learned really is collaboration between disciplines is key. We really have to look beyond working with just clinicians or the clinical group, really to work with respiratory therapists, work with our nurses to improve the care that's being provided to our patients at the bedside, right? As well as to collaborate with interdisciplinary, like the study on high frequency would not be possible without working with statisticians, right? And we want to ask, although we have done quite a number of work within Asia, but Asian PICUs or, is our network ready to collaborate internationally? And really in the PICS ICU domain, there are large international groups. So the PALICC network comes from North America, but they're involving more and more sites outside of North America. The European group has the IPSNIC. The South American group have their own network, and really the Australian, New Zealand group have NHS. So really the question is whether, moving forward, is PACCMAN ready to, collaborate with these large networks, and whether we can really do, really a global PICU study, right? And finally, the last lesson that, we have learned throughout this year is the question of, are we COVID-19 ready in terms of our clinical work in the ICU as well as a research network. So I just want to highlight two recent papers that came out during the COVID period, and this may have potential impact on what we're doing in PACCMAN. And so, this paper from the LAWET network or the South American network highlights that during the COVID period, because of the public health measures that we have taken, the respiratory infection in the PICU has dropped, and this is highlighted in the black bar or black curve that I highlight here. So in comparison with the previous 2 years, the PICU admission in South America, has dropped drastically. And anecdotally, speaking from our own experience in KK, we also see similar trends, right? And so again, looking at some experience in Northern Italy during the lockdown period, investigators again showed that, in 2020, highlighted in blue, there was a drop in, ICU admissions, both unplanned as well as medical ICU admissions. So these two, papers highlight that moving forward, perhaps, those in our pediatric ICU within the region probably have to come up with some plan on how do we cope with the, potential decrease in numbers that we're seeing, at least, over the short term, right? So as mentioned, PACCMAN has grown from year to year, and over the past 5 years, it has expanded close to 30 sites now across, more than 10 countries. But PACCMAN is not without our own challenges. We have to deal with site heterogeneity. We are dealing with different countries that have different healthcare systems. We have different resources. Our clinical capabilities are also different. In Asia, many sites are focused on clinical services, and as such, research infrastructure is not well established. And I think as we do work within a region where internet is key, I think cybersecurity now, of course, is a major concern. As you are aware, the Sing Health informatics or the cybersecurity has been breached, last year, and so we are taking steps to see how we can enhance this so that we can allow sites to contribute data internationally. And finally, whether this this network PACCMAN remains to be sustainable, we have to think of new ideas to secure funding to keep this collaboration alive. So to end off, I still believe that despite the challenges, it is important that we look outside, and I think SDGHI or Sing Health Duke-NUS Global Health Institute is the right direction to go. Singapore, even though it's small, is quite strategic in our location, and perhaps we can really lead some work within the region. So, I'd like to, just like to acknowledge the 10 sites that were, involved in the first study in our ARDS, and really within KK, people like Fu Sheng, who has helped us with, our Chinese collaborators, the Singapore Clinical Research Institute, Patricia, who is there, who is our, secretariat that is doing it for free for us to maintain PACCMAN activities, as well as to all our collaborators who has been doing this work for actually pro bono. And I think what stirred them is really to see Asian data being published and being made known in our scientific community. And lastly, I know I've been speaking over the past 40 minutes, but really I'm just the face behind the team here. Over here is our ICU team. A lot of the work that's been done really is led by Judith, who has put in a lot of effort, in helping the team set up PACCMAN. And really the initial, trust and momentum was, from my ex-boss in the PQ, Prof. Lu Zifeng, who has some faith in us to say that, okay, let's go ahead and try this. And finally, the two important groups here, the respiratory therapists, as well as nursing colleagues in our ICU, where they provide patient care, and without them, really the data that we have or the patient outcome that we have would not be possible. So with that, I would like to thank you and thank for your attention, and happy to take some questions now. Okay, thanks, Amina.
Yeah, so thanks a lot. That was a really kind of interesting journey first of the set, where you walked us through the setup of the PACCMAN, the network, and then the actual research study that, came, the first research study that came out of it. So a lot of interesting detail. So I will start with a couple of questions. Please, anyone in the audience, you can post your questions in the chat box. So please go ahead and do so. I'll start with the question we got earlier on. So I don't know who sent it in, because this was at registration time. Someone sent in the question saying, will PARDS result in subsequent respiratory problems beyond infancy? I don't know whether you guys have looked at that, but certainly from a clinical point of view, that would be so important to know.
Yeah. Thanks, Amina. And that's a good question. And indeed, long-term outcomes is something that we have to look at, right? And as a group in KK as well in PACCMAN, we are trying to look at this. We do not have our data in Asia from our network right now, but I do know of other studies that have looked into long-term outcomes of children with ARDS. However, because it is not a fairly frequent phenomenon, so the numbers are quite small, but we do know that over short term, like 3 to 6 months, they do have some respiratory symptoms, like, a bit more frequent wheeze, for example. Some of them will have some chest X-ray changes still. But, the good news is, after 1 or 2 years, some of these symptoms resolve. So I think it really depends on how severe the ARDS was initially. But, definitely it is an important area that I hope that not only in Asia, but, as a group, PIDS ICU community should look into this. Yep.
Yeah, so maybe just kind of following up with that, is there opportunity to keep track of, whoever's been kind of going through the various, you have a lot of clinical units involved in this in the different countries. Is this, I know it's difficult to do it, especially in the environment of the country, it's difficult, but is there some opportunity to keep track of them as over time?
Yeah, that's also a good point. And I think Singapore, we are quite fortunate because we are very small. So we can always follow up our patients. But for example, in China, where we discuss about long-term follow-up, many of them, after being discharged from the ICU, go back to their province. And they then lose that outcome data, or that follow-up period. So while we are, ideally, we like to say that we like to follow up all our patients, but in certain countries where the provision of healthcare is somewhat different, or at a much larger geographical area, then some of them will unfortunately be lost to follow-up. Right. So to do this kind of work, we probably need a bit more networking. That means, in addition to ICUs, we need to network with their regional hospitals or their follow-up clinics. Yeah. And that will probably take a larger, networking, and of course, more things to iron out. Yeah.
Yeah, and I guess, we maybe think of innovative use of digital technologies, as that goes on. But anyway, I'll go to the second question, which was posed by Ronald Cheong. And he asked that in slide 10 of your presentation, you showed a map of observational studies in RCTs. And he saw that the number of observational studies is higher in Europe and North America, which are cold countries. And he wants to know if weather plays a part in the mortality rate of PARDS.
Yeah, so well, I mean, that's a good question, Warner. And as you highlighted, actually, majority of pediatric studies up to now remains observational. And whether that regional or that change in climate plays a role, we do know that winter, in the temperate countries, they do see more respiratory illnesses for sure. Having said that, during the COVID period, this trend seems to be changed. So I think our colleagues in Australia, New Zealand has mentioned that they have not seen the winter surge that has just passed. So I'm not sure whether we'll be seeing it this coming year. But it remains to I think people have not really examined whether the climate or the winter itself has sort of made an impact on the differences in outcomes. And definitely in Asia, we have certain countries that also has temperate weather, maybe not as drastic as North America, but then we don't see, even within our group, there was not much difference in mortality. We are all around the same spread, so to speak. So no one side stands out, at least for now. Yeah.
Right. Okay. So you had towards the end of it, you brought up some of the challenges, and I guess one of the specific ones I had in mind was, what about data quality from all you're pulling data from so many different sites. How are you? What kind of data are you getting, and how are you ensuring there's some kind of consistency of data quality?
Yeah. So that's key, Amina, and I think how clean the data is or how good the data is really will drive what we can analyze. Right? If you put in bad data, then the results are not even trustable. Having said that, we have to find a balance between how strict we want to be with data, cleanliness versus checking. And so what we do is we have some limits, and there's missing data or something that is sort of seems to be a bit off. We'll make queries to the respective sites, and if there are missing data, then unfortunately we will have to drop that particular patient from that particular site if it's too much missing data. Of course, ideally we would like to have a way to check this data, but that will involve more manpower, of course, and because remember that this first study was a retrospective study with really minimal funding, right? So we didn't have much access to, like to cross-check on their hard copy notes and see, is it accurate? Definitely, if we were to undertake something that's more rigorous, like a randomized trial, all this will be put in place. And so as we plan prospective studies, actually every so often we will be querying the site on certain numbers, right? And so at least that's being audited every so often with prospective studies.
Right.
So I think, given any database study, definitely the integrity of the data always comes into play.
Yeah.
Some missing data for sure.
Yeah. And especially because you have so many different sites and environments to handle. So kind of, I guess, taking that point in a larger perspective, Shreya from our team has asked, what are the challenges of do you face such a large multi-center and multi-country collaboration, and how did you overcome them? So we've talked about the data challenges, but what are maybe some of the other issues that you faced?
Yeah, so I think, language would be potentially one. I mean, even if you want to check, you need someone who is, who knows that language to make sure that numbers it tallies, or what is being charted is what is really meant, And I think, now given that, of PDPA now, we have to make sure that the notes does not have any personal information or patient information when we share them across sites for us to check. These are some of the considerations that we have to consider, when we want to do data checking. Yep.
So I'm looking at the time, but maybe I'll throw one last question at you. And you mentioned in a few different points about other networks and other international collaborations, beyond Asia that exist. So what is maybe potential as well as maybe some of the barriers to link more closely with them? I know in the end that is kind of one of the things you want to do, but how are you seeing that roadmap?
Yeah, so I think one of the things that we can do, and I think the international community is doing really is agreeing on a common data set, meaning for a particular disease, whichever network you are in, you collect certain common data elements so that it makes it easy for us to combine them at a later point in time.
Mhm.
So this will then, will not need us to for every new study we have to discuss again. So if you can ensure that, for a particular disease, certain data elements are collected, and of course you can also collect additional data that's pertinent to your region, but at least then data can be shared and they can be combined at a later point in time. So there are some discussion among the large groups to see whether everyone can come to an agreement of a minimal data set that everyone, minimally collect, let's say 20 data or 20 data points, and then the rest is optional, so that at least in a larger setting, you have that 20 important data points. Yeah.
Okay. Okay, that's great. So I think we are exactly out of time. I'll just say thank you to the audience for being here, and a big warm thank you to Dr. Lee for presenting us this really interesting study. And of course, from the Global Health Institute side, we continue to follow your work closely. We are very engaged with you on a number of research initiatives, and we hope to grow those and certainly see where this such an important, dimension of global health is addressed in a systematic and strategic way. So thank you all very much, and see you again next
Thank you,
month.
everyone. Yes, thank you, Amina. Right.
Thanks.
Okay. All right. Have a good weekend. Bye.
Bye-bye. Bye-bye.